All right, welcome back. We are in the home stretch here. Again, thank you. We see all the participants that are still here. This has been an absolute banner conference with incredible participation. And I want to give a huge shout out to everybody that has spoken, everybody that's been working behind the scenes here to make this seamless. And actually, really, Dr. Liebman, who's been from beginning to end here, a stalwart. So this session is, for those of you that have been to our conferences in the past, we always try to instill a non-scripted live conversation because we really feel, and I think based on past feedback, we learn a lot that way. When you kind of see in a real time of how, docs, surgeons, people think about things and discuss, and not everybody agrees on things. And so we try to pick controversial subjects, but this only works as well as our audience participating in questions. So please, we're going to talk about some controversial things. We're going to talk about some things that push the envelope. And we really want you all to ask any questions you have. And there's really no question that's off limits, so we'll discuss it. So with that said, our topic is talking about all things stroke and Ivtba, and it really comes down to the emergency room. And Dr. Karen Greenberg, who's the director of our world famous neurologic emergency room, which again still the only one in the country and I think in the world actually. But that being said, that's a good thing that if people start doing more and more of this, we hope this becomes a standard of care, as it should be. The data is very clear on this, of having direct point of care for neurologic emergency rooms and specially trained ER physicians who know how to diagnose things quickly and, more importantly, triage. So with that said, what we're going to start is kind of an open discussion, and you heard little bits and pieces of this from Dr. Binning's talk. I touched on it a little bit this morning. Dr. Kelly talked about it. These boxes that we're all in of Ivtba, that's a perfect example of, it's 3 hours. If you give Ivtba 3 hours and 5 minutes, someone's head's going to explode. It's so stalwart with these things. And then now 4.5 hours. So now, as many of you know, we're giving Ivtba up to 9 hours. In highly selected patients, based on data that's been out for quite some time, the Extend trial, and there's actually a couple other trials as well. So, there's some great questions earlier about Ivtba and thrombectomy, and can you do both? Is there an increased incidence of bleeding? And the bottom line is we have to use all of our tools. Dr. Liebman used to give always that great talk about all the tools in your tool belt to use them effectively and safely, but think outside the box. So, and I think one of the other discussions was, what agent to use, right? So, Dr. Greenberg, maybe you want to talk a little bit about that, about, your thoughts on tenecteplase versus, where you think we're going, where we should be going, and what you want to be doing.
Oh, sure. Thanks very much. So one of the hot topics in stroke, and what I think is really cool about this panel is a couple things, is number one, in emergency medicine, one of the things that keeps changing is care for stroke treatment. There's really not a lot of exciting things that's going on with heart attack. There's not really a lot of exciting things that's going on with sepsis. Stroke is the one thing that keeps changing. And the other thing that's really cool is that you have a panel of 3 neurosurgeons up here who are really passionate about treating stroke, because we know that you guys like the aneurysms and you like the tumors, but it's really, really neat that you want to help stroke patients because of the disability. And one of the new hot topics in stroke is that there's a new lytic on the block, and it's called tenecteplase, or TNK. And that's why we've been trying not to say TPA. We're trying to say alteplase because TPA and TNK sound familiar. There's really a lot of advantages of tenecteplase, so much so that we are looking to switch our lytic in the next month. And the only reason that it's delayed for a month is because we just switched the EMR. And tenecteplase is a 0.25 mg per kg bolus, and it is a one-time shot over 1 minute. So there's no messy calculations. I'm going to bolus 10%, and then I'm going to drip the rest over an hour. And another really key thing for all of our spoke hospitals out there who are listening, if it's a one-time bolus, now for all of your transfers, we've just simplified that process immensely. There's no messy drip.
Maybe you don't need a nurse to go with the patient if they're not intubated and not on cardine. If everything's status quo, we're just going to get that patient on an ambulance to my colleagues that are sitting up here, because minutes do still matter. Yes, we're getting away from time windows to tissue windows with advanced imaging, but at the end of the day, the faster that we can treat with IV therapy or thrombectomy therapy, the better outcome for the patient.
So, Karen, can you talk a little bit what are the negatives? Why wouldn't somebody use tenecteplase?
I think that we at GNI like to push the envelope, and the biggest hang up is people are going to say that it's not FDA approved.
But aside from that, just correct, and that's really why we haven't done a lot of things. We wait a decade is because of, but just from a strictly scientific patient care and experience standpoint, what are the arguments, if there are any, outside of the, getting it through the hospital policy and all that, but just the actual science of it? What is the downside to using tenecteplase? Because there's clearly many upsides.
Yes, so there's many upsides. I think, truthfully, the basic argument is that there are still, unfortunately, a lot of emergency physicians that are very fearful of giving any type of lytic because of the risk of intracranial hemorrhage.
So is there a thought that there's a higher risk of hemorrhage? Is there any data that suggests that the hemorrhage rate of tenecteplase versus alteplase?
There shouldn't be. Actually, their rates are very similar, or maybe even slightly less with tenecteplase.
And so I think this is a perfect example of, let's take everything out and talk about fact and science. So, I mean, my argument would be not only there's zero reason not to use it, you should be using this. This is a better agent. It's a safer agent. It's different. That's the only thing. And I think that's kind of, it's really interesting how these things don't get done because of just, gestalt, really.
Yeah, the red tape of trying to do something like that. The other thing is, and we never want to focus on that completely, but adding it into the picture, tenecteplase is actually cheaper than alteplase.
Yeah, which tells you right now, for all the hospital administrators out there, that's going to be like, But again, there's literally zero reason not to be doing this. So, I think it's incumbent on us again, and kudos to you, and kudos to the hospital systems that are allowing us to do this, so that we can provide better care and better standard of care. What about?
I'm just going to add in now. There's actually a national alteplase shortage, so there's a shortage of 100 milligram vials. We're using 50 milligram vials, so even more reason to use tenecteplase.
Yeah, so. And just like Zoom with COVID, right? I mean, it's gonna be something. And once people start using it for that reason, which shouldn't be the reason that they're using it, everyone's gonna start using it and be like, my God, why didn't we do this sooner? While you have the mic, can you speak a little bit, because there was a lot of questions we got throughout the day again about that IV lytic, we'll call them lytic. And intervention. So can you talk a little bit about, is there any argument to not do one over the other, timing, risk of hemorrhage, any of that?
So the original randomized trials that were positive for thrombectomy compared TPA alone to alteplase, so it is TPA, but alteplase alone to alteplase plus thrombectomy. And the thrombectomy arm was superior to the alteplase alone arm without a significant increased risk of hemorrhage. Then, because thrombectomy has been so successful, even with the Dawn trial at 24 hours, the next question to answer was, well, do we need thrombolytics at all? Do you do more of like a cardiac protocol where you just go straight to the cath lab? And the truth is that study's been done, and the arms were TPA or alteplase plus thrombolysis versus thrombolysis alone. And it showed that the two arms were basically equal. Skipping TPA was not inferior to administering TPA, and the risk of hemorrhage was not less by foregoing TPA. So I think we all sort of have the same philosophy that there's a lot of time where you're waiting, whether it's with transferring the patient or, your team has about 30 minutes to get in and set up the room to get the patient on the table. You can have your alteplase infused by that point, so you might as well do something while you're doing nothing. So in some instances, if you can get the thrombectomy done before you can administer the TPA, that might be a reason to forego TPA. But in terms of hemorrhage risk, there's really no significant difference with alteplase alone, alteplase plus thrombectomy, or thrombectomy alone.
It's a great point, Dr. Benning, and I can't agree more. One of the things that we're trying to better create is a better pre-hospital stroke. So we're trying to understand from EMS as well as the ER docs, what's the likelihood of a large vessel occlusion? Because as we know, TPA is not, or whatever we're going to use as an IV lytic agent, is not great in terms of revascularizing a large vessel occlusion. So that, it's not foregoing or bypassing because it's safety, but because it's more efficient. As we said, yes, we've extended the time window, but all the studies show faster, better. So maybe, again, not purposely avoiding, but if it's a large vessel occlusion, getting to a center where you can offer endovascular therapy immediately.
If I could just add one more thing too.
Yeah.
The STEMI analogy. What's unique about stroke is whereas 100% of patients with STEMI on their EKG go to the cath lab, maybe, and if we're being generous, it's about 15 to 20% of stroke patients go to the interventional suite with all of you. And the scales are deceiving. I've had patients with an NIH stroke scale of 20 who have the large vessel occlusion, and I've had patients with the NIH stroke scale of 20 who don't. And their stroke is just in an unlucky place. It's in the thalamus, it's in the anterior limb, posterior limb that takes out your face, arm, and leg. And there's no way to know that until you do your advanced imaging. And that's where the minutes are going by that are important. So I think that's really important to talk about too, that we are not at stroke care where 100% of patients go for thrombectomy, and I don't think we ever will be. There's just too many vessels.
Yeah, no, it's a really, really good point. There's a great question that actually comes up over and over, and I think is a really important one, and I'm going to open this up to the whole panel. What is the recommendation of the use of Plavix after someone's had a stroke and they've been on aspirin? So basically failure of aspirin. And I really want everybody's opinion, so I'm going to give the mic to Dr. Liebman, and then we'll go down the road for everyone's thoughts on that.
Well, the first way I'm going to respond or answer that is it's somewhat obvious in that obviously we have to understand what the stroke was due to, meaning if the patient has an irregular heartbeat, atrial fibrillation, then obviously aspirin is not adequate, and we would be even more aggressive, putting them on Coumadin or more often now, a direct oral anticoagulant. If the patient doesn't have an obvious reason to be on a more aggressive anticoagulant, then we do a vascular workup. So we look at the blood vessels both in the neck as well as the brain, but we will often put patients on, we actually, let me phrase that, we almost always put patients on dual antiplatelet for the 21 days, and Dr. Kelly mentioned about the CHANCE trial, and that is correct. So we put people on statins, high dose, and we put them on dual antiplatelet, and then once they see us in the office, we start adjusting whether or not they should continue on that, should we stop the aspirin, continue the Plavix, stop the Plavix, et cetera.
Yeah, and I think that's a great answer, but also the failure of somebody is on an agent, there's no other factors, they've had a stroke on that, that's where there's a lot of debate. We were just talking about this earlier this morning, right? About you can ask 10 neurologists, and everyone's going to give you a little bit of a different answer, and there's some nuances to it. You have the mic, so we'll.
Yeah, I totally agree with Dr. Liebman that you don't want to keep someone on a therapy that has already failed, but you also want to know, why did it fail? Did it fail because you have a carotid stenosis that needs stenting or an endarterectomy, or did it fail because you have small vessel disease and your hemoglobin A1C is 12 and your mean arterial pressure is 120 at all times? I mean, you really have to manage the risk factors. But at the same time, I think that we tailor our antiplatelet agents to make sure that we go a step beyond what has failed. So after dual antiplatelets for 21 days, if they failed aspirin, we'll probably keep them on Plavix.
Yeah, I don't know if you. Anything to add?
From my standpoint, in the ER is probably the easiest answer. If you come into the ER and we think that you've had a stroke and you're already on aspirin, we're going to add Plavix for those 24 hours and then let you guys vet it out on the inpatient side.
Yeah. And I think one of the other things that I would stress is there's nuance. You know, we can do protocols for a lot of things, and protocols are great guidelines. I don't think we've done a great job, particularly in stroke, where everything is so rote that sometimes we lose. And we were talking about this a few days ago. You know, I recently saw a patient in the office who had a carotid stenosis, but they had a fresh thrombus within their. That's a very different disease. That's a big piece of, jelly sitting there. And we're not going to do any intervention because we're just going to break that off. But the goal for that is not aspirin. That's like a heavy anticoagulation to let that thrombus dissolve and then reevaluate. But again, I think those were great answers, and I hope that answered that question. So as far as the triage of these patients, so we've been a long way from patients coming in and, oh, that's interesting, it's a stroke. Go up to the medical floor and we're going to get an MRI in the morning, right? I mean, we lived through that, and I think many of us did. Now we have all these different devices and medications and protocols, and I think the pre-hospital stroke alert really was a game changer of getting from our EMS colleagues, of our first responders, and getting them quickly to the CAT scan table, getting them quickly with already their EKG, their blood glucose, everything, so we can go ahead and give IV lytic quickly. One of the new things that came out, and again, talking about technology and trying to find a place for it, is the mobile stroke unit. So I can't, and I'm sure you guys as well, and gals, get asked that all the time. And I love it because if you remember back in the day at another place, I'll leave it at that, we were going to do that, right? We were going to put a serotonin in the back, and we started talking about that, and we looked at the practicality of it, and it just didn't make sense because we were like, how are we going to beat the pre-hospital stroke alert? Now it's everyone, you can get a CAT scan. So I know you just gave a lecture on this, Ken. So I want to give, just get your thoughts and from an EMS, from an ER standpoint, and also from a vascular standpoint. So what are your thoughts on the mobile stroke unit and getting a CAT scan in the field?
Silly. That's the answer. Silly. It's again, it's sort of like a lost leader. It's something that sounds cool and they're going to promote, but if you think about the logistics of the mobile stroke unit, so you have to have specially trained individuals. So those people have to be available. So it's personnel is an issue. You have to go to a flat surface. So that is no longer a speed helpful situation. You can't be moving along, going to the ER while you're doing your CAT scan. So yes, if you're in the most rural locations where you don't have any local ERs you can't get to, then maybe it's of some benefit. But in this location, I do not think it's cost effective. I don't think it helps out overall door to needle time, door to CAT scan, but door to needle time, door to endovascular time. So I go back to, I think it's silly.
Yeah, truthfully, I couldn't agree more. I think in this area where we have many hospitals in our catchment area, it's not needed. It's probably needed somewhere in Montana where your closest hospital is 2 hours away, or you're getting airlifted somewhere. I'm not sure how it works. But I couldn't agree more. And I think the cost of running it too, especially after this COVID pandemic, Dr. Liebman just mentioned, like, you physically have to stop the stroke bus to get the CAT scan.
And be on a flat surface.
So flat surface and stopped. And it's $1 million for the CAT scan machine itself. And then it's $1 million to run that program. So I couldn't agree more.
Yeah, and people forget you have a team, a specialized team, plus the tech that's sitting there 24 hours a day, 7 days a week, just waiting to go out. It's just it doesn't make sense.
Yeah, I'm actually more excited about the portable or mobile MRI. It's a very small unit. You can actually be wearing your medal. It's actually a very confined device or MRI machine, and it would fit very easily in an ambulance that doesn't have to be stopped. So I think the technology for that is actually more promising.
Yeah, no, absolutely. And for many of you that don't know, there are now portable MRIs, which actually we're going to put one in our neuro ED, and that might be a very logical next step. So we're just we're here in GNI studios, and all the speakers that were here today are actually drinking out, and I'm looking right at them. So I wish all of you were here as well. So, but I don't know if we can say that. There's no FCC things, but so we have some more great questions here. So all to place greater than 4.5 hours.
Yeah, so that's something super unique and cutting edge that we're doing with GNI and in the Neuro ED, where we are expanding the window, the time window. So we're specifically going to talk about time and then tissue. And what's interesting is we actually do a terrible job of treating stroke patients here in the United States. If you look at all of the patients with a discharge diagnosis of stroke, only 3 to 5% of those patients were actually treated with a fibrinolytic IV. So what we're trying to say is maybe the 4.5 hour window is too short. Can we expand it to 9 hours? And we have actually done that successfully at GNI. The key about the 9 hour window that the audience needs to understand is that it's not just time of 9 hours, it's tissue dependent, meaning these patients need to get into an MRI machine and have a diffusion mismatch. Or what we do, they need to be put in a CT perfusion machine and have at least 70% penumbra or more compared to the ischemic core. So we're looking for the ischemic core to be 30% or less. So you have a good amount of salvageable tissue in your brain. As of today, we've treated 6 patients in the 9 hour window. 0 of them had any type of intracerebral hemorrhage, let alone a symptomatic intracerebral hemorrhage. And I've actually seen one of our patients come back, and he's doing great.
Yeah, and that's the next step, is really looking at outcomes. But, again, being able to offer something to somebody, more is better in this case, and as long as it's safe. And I think our European colleagues have already shown a while ago that it's safe.
And I think the key is I'd have to actually look at our data, but several of those patients were not candidates for a thrombectomy.
Right.
So therefore, the only treatment that they were going to be offered was aspirin and Plavix,
Yep.
the question that came up. And here they actually got treated with an IV fibrinolytic. And the one gentleman that I've seen come back, he went home like 2 days later.
Yeah.
But it's important to clarify, they weren't candidates because there was no LVO.
Correct.
Because we extend our endovascular therapy well beyond, as we talked about the Dawn trial multiple times, up to 24 hours.
Yeah, or even beyond. I mean,
Yes.
The Dawn trial is a guideline. It's a randomized trial that says 24 hours is safe and effective, but we'll extend the window out for 2 or 3 days if the patient has salvageable tissue. So we will always give the patient a chance.
Yeah. Here's a great question, which is near and dear to my heart. So I've been on a personal mission for many years. This question is, in addition to the Nih Stroke Scale, what's most clinically beneficial in monitoring, clinically observing a patient in an acute stroke? I'll start it off with some controversy. I think the Nih Stroke Scale is one of the dumbest, most complicated. It's irrelevant, I think, for stroke patients. I won't get into the history of it and who did it and why they did it and all that, but it's not practical. It's just, if you think about it, it's just not practical. We use Hunt Hess for subarachnoid hemorrhage, right? We all talk with the grade 5. Everyone knows what a grade 5 is. Even grade 3, okay, that patient's lethargic. We make it simple. And so I think the RACE score is a really great thing because there's a predictive value for large vessel occlusion, which is important. But we need a better grading scale that's just down and dirty where everybody knows. And, because Nih Stroke Scale, let's really be honest. We talk and we communicate with each other all the time. It's high or low. And you're you're looking at those thirds of, it's a 20, it's a 10, right? Yeah. And as opposed to something that's a little bit more specific. And then we always have to ask the question, is it upper and lower? Is it, you're not thinking, it's just not a practical scale. The question is there something better clinically? And, what I would say is common sense. And if somebody, wants to add to that, it's, we give these lectures all the time, especially to EMS and our ER colleagues. strokes are pretty, if you put it into buckets of simplicity. You're in the field, you're getting called, you're coming in, and there's a patient at the dining room table, and the man's wife is saying, we were just eating dinner, and all of a sudden, acutely, he couldn't talk to me, and then all of a sudden, his right side went out. That's two things. And let's take out it's a rare form of epilepsy, and it's this and that. It's two things. We know where the lesion is. We know where the side of the lesion is. It's either a hemorrhage or it's an ischemic stroke. That's it. That's the fork in the road. So think in that way. There's very few things that are going to mimic that, right? And some of these outliers of like syncope and this and that and like unilateral visual loss, those are usually more chronic. And again, if anybody disagrees, I think we need to get into that things being common and focusing quickly. So someone has obvious stroke symptoms, and the ones I just mentioned, they need an immediate CAT scan so we can figure out which fork in the road.
And the other thing you didn't mention, which I completely agree with everything you said, is what about the posterior circulation infarcts? Right. Every one of our scores have been not good with that. And I think we need a very simple thing that also encompasses the posterior circulation. Because let me tell you, as we all know, those are the deadly strokes, right?
Exactly.
Yeah, I agree. And I think even, our ICU nurses can attest to this, that you could have a very subtle change where maybe you have a subtle facial droop and maybe it's a little bit worse, or a drift and it's a little bit more drift, but it's not enough to give you a point on the scale, but it's enough that nursing knows that it's different. We know it's different, but you don't have an objective way to say how it's different. So a lot of it is also your knowledge of that patient and knowing what their baseline is and knowing how that baseline has changed. And I don't think the NIH scale always captures that.
Yeah, absolutely.
Yeah, you guys pretty much said everything. I think what a lot of people don't understand just quickly is that the NIH stroke scale was supposed to be a research tool, and it was never supposed to translate to the bedside.
Exactly.
But here we are in 2021, and the NIH stroke score is still the quote unquote gold standard of what we do. And I've actually been joking for years that I'm going to make the GNI stroke scale with that we should do that because the posterior strokes was a great point. It's actually biased if you're having a left hemispheric stroke that gives you more points for language. It could be a whole other talk in itself. And the bottom line is that it has significant drawbacks. You can even really just break it down to the Cincinnati stroke scale, and that if you're face, arm, and speech, and if you have one of those three things, that there's about a 2/3 to 70% chance that you're having a stroke. And that's why the brain's complicated and why we have these discussions.
Yeah, no, absolutely. And I think it is coming, and I think we do need to simplify it. And there's a question about stroke training opportunities, and I'll just say there are plenty. And if anybody's interested, just let us know at GNI. I mean, you can get on the WOVA platform. You can reach any of us anytime. We routinely and frequently at all of our sites, all over the place, do these. You saw our incredible PAs and advanced practitioners who are part of that team. Our neuropharmacists are also part of that team, and we have a multidisciplinary group. As you see, we kind of try to make things common sense, and so we're happy at any time. And if there's a group of you, if that's from a certain hospital, we're happy to arrange it. We do it all the time. If for any of our colleagues at Lourdes that have some new staff and need that training, we're happy to come and do that.
Yeah, it's literally a course, Advanced Stroke Life Support. And It's run by GNI.
Yep. We do the certification through GNI, but we also, even if it's just a refresher for ICU nurses, for ER team, Dr. Greenberg can come with us to talk to the ER colleagues. We're happy to do that. That's what we're all about, is education. We don't see things as competition, or we're happy to do that. So I want to shift gears a little bit, and again, let's talk about some of the things where we needed to push that envelope, and again, innovation, which is the theme of this year's conference. One of the things that we also drove us crazy, and we did something about, and Dr. Benning did something about, is the nonsense of immobilizing patients like they're going to explode in 10 minutes after they get Ivtpa if you touch like a souffle in the oven or something. So the one downside of not having the audience, which we love doing all the time, is, we would offer free dinners and a date night with Dr. Liebman for if anyone got this right. But, what's the half-life of Ivtba. We can, if we get some questions, you guys can Google it, but the half-life is really short and the terminal half-life is minutes. I mean, it's out of your system, literally even detectable. In 45 minutes, you're not even going to detect the Ivtba in your system. So what do? You can't get Plavix, you can't get aspirin, you can't get out of your bed, you can't get blood draws, you can't get physical therapy. It's ridiculous. It makes no sense. So Dr. Binning, if you want to talk a little bit about what you're doing and the paper that we just did and your study that you did.
Yeah, so exactly. I think it drives all of us crazy that we have to hold therapeutics and therapy, even a blood draw, because of this arbitrary time window that doesn't actually pharmacologically make sense. And so with the help of Natalie Goffman and Christina Maxwell, we developed a protocol that's based on fibrinogen. Now, if you think about a patient who's had a post-alteplase bleed, fibrinogen is actually the marker to determine if we're going to infuse cryoprecipitate. And we look for a fibrinogen level of greater than 150 to determine the patient's risk of bleeding, essentially. So if the fibrinogen level is greater than 150, we don't necessarily have to infuse cryoprecipitate or do anything to reverse the thrombolytics. So the idea was we're going to create an 8-hour window rather than a 24-hour window. And at 8 hours, we get a plain head CT like you normally would at 24 hours, make sure that there's no intracerebral hemorrhage, get a fibrinogen level, and as long as it's over 150, we will actually start therapeutics, whether it's anticoagulation or antiplatelet agents, allow the patient to get out of bed, work with therapy, get blood draws. We still abide by the 24 hours for the blood pressure parameters post-TPA and the Q1 neurochecks and vital signs. And to be honest, a lot of that is just for Joint Commission, so we don't fall out of those metrics, not because we are worried that the patient's going to bleed. But that's the protocol. They stay Q1 neurochecks, vital signs, and blood pressure parameters for 24, but they're able to do all of the rest of their post-stroke therapies and treatments at 8 hours. And what we found is that there's actually no increased risk of any bleeding complication, intracerebral hemorrhage or GI bleed or any bleeding complication. And I think really the trick is that really screening those patients with a fibrinogen level, or if there's any blood on CT, then the patients stay within the 24-hour protocol. So we're not actually causing any increased risk, because if they don't meet those criteria, they get the 24-hour protocol anyway.
Yeah, and for our physical therapy and rehab and physiatry colleagues, please push this at your hospital. We're happy to share a protocol with you because getting these patients immobilized early is critical, as everybody knows, and this really achieves that. And again, let's look at the stupidity of why we're doing these things. And we just, this is where these protocols, people stop thinking, and they just kind of blindly do things without, thinking about what's best for the patient. We have another question. Oh, I'm sorry. Yes,
something
absolutely.
from the ER standpoint there too. For the emergency providers that are out in the audience, I always think it's a little bit interesting in the ER. So we've given alteplase or we've given tenecteplase, and nobody wants to put a second IV in the patient, or maybe that patient needs a Foley and they don't want to do the Foley. The half-life that you alluded to is 3 to 5 minutes. And I always say to them, so these patients that got an IV lytic and they can get a thrombectomy, the 3 of you are literally going to puncture their femoral artery. Okay, so the IV and the Foley or the blood pressure every 15 minutes that needs to, the venous, hopefully it's venous. It's okay. Because if you translate it to what you guys are doing in your intervention suite, you're literally puncturing an artery. So it's safe.
So we have 2 great questions here, and one of them is, and I think that Dr. Binning alluded to this, intraarterial verapamil as a neuroprotective. So this is another thing that we started doing. Because we do a lot of these great cases, and you've all seen it. Here's a blocked artery do a roto-rooter, the artery's open, we all congratulate ourselves, look how great the picture is. Well, you know what, all these patients don't really 100% do well. You know, many of them do, but many don't. And even though we have a perfect result clinically and arterially and surgically, you know, we need to start delivering neuroprotectives to the brain. And we've been so far behind with that. And again, kudos to our neuropharmacology team and Natalie Goffman and Christina Maxwell, who we think of all these things and say, look, we want to get this done. Whereas at most places, especially the academic institute, oh, we can't do that. It has to go to the IRB and there's legal. So we started delivering intra-arterial verapamil after acute strokes in selected patients to be able to help those brain cells that are really on the fence recover. And there's some good data that verapamil as a calcium channel blocker is a really good drug to use to help stop apoptosis. But, you know, instead of getting into a debate about, well, there's better drugs. Okay, great. There probably are. But until we start delivering neuroprotectives after a stroke, we're not going to get there. So we are doing that. We're doing that actively. And what we're looking for right now is the best drug to use. But there's a great question here, and I want to spend some time on this. So has GNI considered engaging Joint Commission to incorporate these evidence-based models you've discussed? I'm going to start off with my thoughts, and you want some water? Yes. The Joint Commission, I think, has failed hospital systems. I think it's a money-making entity. I will tell you, I can think of, and we all know, there are centers that have JACE. They pay their yearly dues. They do the dog and pony show. And you know what? Every time an acute stroke shows up that needs intervention, oh, guess what? Our neurosurgeon's not here. Oh, guess what? We're shipping it to our affiliate. You know, there's not a lot of oversight. It's pay your check, come in and say you're doing all this stuff, and you have an interventional, you know, all the checks. And so I think we need to do, and it's a great question. The reason I love it is because we're trying to shame Joint Commission. We're trying to say, you know, my question is, well, why isn't Joint Commission doing this and saying we approve this? You know, why aren't they saying that there's evidence-based data on a European trial, and we're going to go to, they have access to every one of these centers and say, you know what, you're a high volume center with high quality and good outcomes. Would you be interested in being in this multi-center trial because this is best for the patients? No. So I have a real problem with Joint Commission. I don't think they're doing a good job of oversight. And I know what the answer is because we've already kind of challenged them on this. Well, financially, last I checked, they're doing pretty well financially, and it's not cheap to be a Joint Commission center. So I'll leave it. And again, that's open for the audience too. Please, let's get some, thoughts on this. And I'll start with Dr. Benning.
So I have a couple of examples. The first is with tenecteplase. You know, that randomized trial has been out for years now, probably 3 or 4 years. It was done in Australia. It actually showed improved outcomes with tenecteplase compared to alteplase. And it's really only been in the last year and a half, is it, Karen, that the Joint Commission even recognizes tenecteplase as an alternative to alteplase for a trial that was done probably 4 or 5 years ago. So if you look at our our TPA protocol with, you know, the 8-hour protocol, I think the first step in that is getting it published. But even the medical journals, so the neurology journals, the critical care journals, so far they haven't wanted to touch this paper because they're worried about some, you know, mysterious liability that they don't have, that even though we've shown that it's safe, they're still really married to this 24-hour protocol. And I think before the Joint Commission even considers adopting it, we're going to have to get our, you know, neurosurgery, neurology community as a whole to adopt it and accept it. So I think the first step is getting it published.
Yeah, no, that's a really good point.
Yeah, I think from my standpoint is, and I think you guys alluded to it, that we can engage the Joint Commission, or we can just be cutting edge and push forward and create change on a daily basis, which is what we've been doing for several years now.
Yeah, and I think what we want to do is exactly right. Is listen, we're not always going to be right. We're not always going to, and we're going to learn. but we need to do it as a team and as a community of healthcare providers. And I'll be very honest with you. I'm not really even sure what the role of Joint Commission is. I mean, we've already know what the standards are, right? We know, okay, you have to have these things. Do we need a private entity that comes in and does this? I'd be all for it if they actually police the centers and we had to report volumes and there was a check and balance of if they're actually there, because I think it does a great disservice to, I mean, how many EMS talks do we give a year? I mean, between the four, I mean, a lot. And it's always the same question. You know, Dr. Vez, Binning, Greenberg, Liebman, where should we go? Where should we bring our patients? You know, because we go to hospital X and they're, a thrombectomy capable, but a lot of times there's nobody available or they're not there or whatever. So it's, it's black and white. If you want to be a stroke center, that's great. And I'm really happy that there are as many stroke centers as there are now, and there are as many comprehensive centers. That's a good thing. There's no competition in that. That's saving lives, and no matter who it is or what system it is. But there should be a bar of doing it right and doing it with the right standard. So I think we have a few minutes left. So I think this was certainly fun for us, and I hope that everybody learned something. And again, please fill those evaluations out because it helps us each year make this better and more applicable to all of you. It was really fun, honestly, doing this, and we really look forward to seeing everybody next year. We will be live in person, I promise, I guarantee, unless there's another pandemic, and we don't have control over that. But we will definitely be live and in person. And again, I want to thank from all of us at GNI and personally our incredible hospital partners, and particularly the sponsors, Crozier Health, Redeemer Health, Robert Wood Johnson Hamilton, who all the things that you hear us doing and these trials and all this great, they're trusting us, they're letting us do this, and they're providing better care to the patients in their community and in their hospital system, because patients that are going to those systems are getting this level of care, and they're not getting it anywhere else, especially the things we just talked about. So thank you. And also thank you to our industry partners. I think the theme of this innovation was really our partnership with industry. We couldn't do what we do without you. And we really look forward to kind of, the next phase. And as you know, here at GNI, we're going to do it fast and swiftly, and hope to challenge ourselves and everybody else to provide better patient care. Thank you all very much. Have a great weekend.